see you all together on such an important issue for general practice. I just want to quickly introduce, it's Sarah and James, who are medical students from the University of Sydney, and Sarah and James are going to be doing some role-playing to show you some of the techniques around motivational interviewing. Just for ease of role-playing, Sarah will be playing the GP throughout, and James the patient. That is in no way to suggest that it's always men that we see with substance problems, because we know that's not the case, because women are represented just as much as men as well. And the other thing I just want to do is just acknowledge that I'm sure that there are lots of people sitting in this room who already know some things about motivational interviewing, and that some of you are probably very good at it and use it in your consultations all the time. Some of you might know something about the theory of it and be not quite sure how to kind of transfer that into practice. Some of you might sort of think, well, I've heard of what it is and I'm really not sure of the theory about it. So I've tried to sort of bear in mind that there'll be that whole degree of expertise, and I hope that this presentation has something in it for everyone, no matter which group of people you feel you're in. So up there is the learning objectives for this section of our day, and I'm just going to jump into a hypothetical patient-doctor scenario and describe this for you. So let's imagine that you're a GP and one of your patients comes in. You've been seeing this man for, say, 20 years, and for the last 15 years you know that he's been drinking a lot of alcohol. So most days of the week, most weeks of the years, fairly large quantities of alcohol, which is definitely harmful to his health. And every time, well, maybe not every time, but a lot of the consults that you've had with him, you have touched on the issues. You've sometimes tried to do a bit of counselling yourself. You've referred him to drug and alcohol services, referred him to some support services, and maybe you've even sat down and drawn a diagram of every organ on the body which is affected by alcohol. And every time you see him, he says, oh, yeah, right, and just wants to get on to another part of the consult. And he says, look, I know all this, and nothing seems to change. And then you don't see him for a year. And he comes back and sees you, and he says, you know what, by the way, 6 months ago I stopped drinking. And you say, oh wow, that's really great. So what happened? And he says, well, my brother, who was a drinker like me, died. He died from liver failure, from his alcohol. And my niece, his daughter, came to me and talked to me and burst into tears and said, I gave my dad a really hard time. I never had a chance to really talk to him before he died and say sorry for all the stuff I did. And your patient says to you, and I immediately thought, not just of my brother, but my own kids. And I thought, I just don't ever want to put them in that position. That's it. I am never going to touch another drop ever again. So despite all your best efforts as the GP, nothing changed for a long time. But what that patient found was motivation from within himself, based on what mattered to him, and that's how he was able to achieve that stop. And the golden nugget about motivational interviewing is that there is strong evidence that if the GP had maybe engaged in that consultation style earlier, it would have been quite likely that that patient may have begun to decrease or look at his alcohol use many years before that, and that all those changes could have happened within the context of the GP-patient interaction. Okay, so what is motivational interviewing? I mean, in a nutshell, it's basically a consultation style. It's a way of having a conversation, and it is all about change talk, and we're going to talk a lot about that and get some demonstrations of that today as well. So, you know, when we find that we are repeatedly advising our patients to do something and nothing is changing, it's not just about the patient changing what they're doing, it's us looking at what we're doing and knowing that we've got to change strategies, and moving into a consultation style of motivational interviewing is a really excellent thing to do if you feel things are not moving along. So it was originally used in alcohol settings and is widely used in drug and alcohol settings, and it's gone way beyond that too. You're probably all aware that it's often a style of consultation that's very effectively used with chronic disease management as well, when we're trying to get better outcomes from chronic diseases that require a lot of lifestyle change. So in motivational interviewing, we don't tell the patient what to do, but we also don't just passively listen either and nod our head. So what we're actually doing is trying to guide the patient towards some kind of change talk. And we're trying to sort of step into the role of helping our patients find out from within themselves what is it that matters to them and is going to help them change. What skills do they have? Help them find out what are my resources, and help them also, I guess, define what the problem is, own the problem themselves, and take ownership of how am I actually going to do something about this. So the other great thing about motivational interviewing is it allows us to develop a really nice relationship with the patient, with a very strong rapport, because it's not about who's the expert and who's the recipient. We come together really at the same table and we share our ideas and we have a conversation about it, almost like a partnership, if you like. So basically in motivational interviewing, the first thing we've got to do is help people through stages of change. So I'll just be quick about this one. I mean, motivational interviewing and assessing stages of change are not the same thing, but they are very intertwined, and you have to know the basic concepts of stages of change to be able to be effective, I think, in your motivational interviewing. So the stages of change model in drug and alcohol settings often proposes that patients will move through these stages. I mean, things don't work out exactly like that, and you don't necessarily go from stage A to B, but it's a model that gives us some help in understanding what goes on. And motivational interviewing can be used at any stage, but it's particularly effective in the pre-contemplation phase, the contemplation phase. Just remember that, because it's powerful as anything in that I'm not sure stage. And it's also very effective in the determination phase as well. You'll see, I see up there is a little section that's got relapse in it. Just a quick word about that. I don't know if that's best described as a stage or not, but it's important that if anyone we see does move back into drug and alcohol use, that we help that patient, make sure that patient doesn't see that as a failure, because I know all of you would have seen people who have taken 3 or 4 or 5 times to give up tobacco. You know, they've come back and they've said, oh, I've finally done it, but you know, it's not been my first go. And we know that that happens, and quite possibly what's happening is each time you make an attempt, you're actually learning about your own resources and how things work for yourself and what might make it better next time you try it. So we've just got to be really careful that when we reframe, we talk to patients if they've come back and they've relapsed, that we don't frame that as a failure, but I guess more as an opportunity to try again. So quick refresh. What we're going to do is just do some quick role plays now. So firstly, here is a demonstration of James, who is in the pre-contemplation phase. So I just want you to have a listen to how James is not at all acknowledging of his alcohol use.
Hi James, good to see you today.
Oh look Doc, I'm in a bit of a hurry. I've got an appointment at Centrelink at 12, so if you can just write me my scripts, I'll be out of your hair.
Yeah, sure thing, I'll get on to that. But do you mind just quickly if we have a chat about your cutting down of your drinking?
Sure, you can check. And no, I haven't thought about cutting down my drinking at all.
Okay, so we had a bit of a chat last time about your alcohol consumption, and I thought I'd like to see where you're at now.
Well, I don't think it's a problem. All my life I've been told what to do, and now I'm making a stand for myself. That's a good thing, isn't it?
Sure.
Besides, I've tried to give up thousands of times before and it's failed, so it's pretty much a waste of time. I've worked hard all my life, I've had a hard life, and it's my relaxation. I actually think it's probably better for my health if I keep drinking anyway.
Okay, so James doesn't sound very interested at this stage. So what is our job as the GP if we're in that kind of consultation? I think our job is to increase James's perception of the risks of his alcohol use, to give James some information about that, and offer some information about harm reduction, and maybe most important of all is to make sure you keep the door open. Okay, so make sure that you let James know that you're open to talk about this at any time again. So let's now imagine that James has moved on and is coming back in the contemplation phase. So please very carefully listen to this. This is a golden nugget for some of the techniques we're going to be listening to. And you'll hear James's ambivalence about his alcohol use.
Hi James, good to see you again today.
Look, Doc, I'm in a bit of a hurry. I've got an appointment at Centrelink at 12, so if you can just write me my scripts, I'm not going to take any more of your time.
Of course, I'll get on to that. But first, do you mind if we quickly check up about whether you've had any thoughts about our chat about alcohol last time?
Well, I mean, I don't really know. I mean, I've thought about that I don't really want to die from liver disease, and I want to see my kids grow up, but I like the way alcohol makes me feel. It makes me confident. All my friends drink, and I'd miss the fun that we're having together and the times that we share. And I'm sure it decreases my stress level.
Okay, so you can hear some weighing pros and cons, ambivalence. So if you hear that who you're talking to is in that phase, our goal is to explore that ambivalence, and we're going to spend quite a bit of time a little bit further down looking at how we do that. But just before we do, I just want to demonstrate one final stage of change, which is the determination phase. So just have a listen to how our GP helps James firm up on a kind of realistic plan of action.
Hi James, good to see you today.
Hi, Doc. Look, I'm in a bit of a hurry. I've got an appointment at Centrelink at 12, but I've been thinking about what we talked about last week, and I think I want to give up the grog.
That sounds fantastic. Have you made a plan to start?
Yeah. I've had some thoughts about it.
Okay. What does your plan look like?
Well, I called that number you gave me, Melissa at Smart Recovery, and she was really supportive. I felt like I could finally go ahead.
Okay. So what are the steps you plan to make in the coming weeks?
Well, I've got to work out which groups I can go to. They've got some evening ones that don't clash with work, but my son's got the car most nights, and public transport's shit.
So is there any way you can kind of come around that issue?
Well, I've managed to talk to my wife, Julie. She normally doesn't believe in this sort of counselling stuff, but she's actually been really supportive on this, and she's going to borrow her sister's car to get me there.
Okay, so that's firming up, that's the determination phase, and you can hear how the GP, probably at no stage there, suggested or told James what that plan was going to be. It was hearing from James, what's your plan, what's your plan, what's your plan, and supporting where that was appropriate. So you can use motivational interviewing at any stage of change, but just remember pre-contemplation and determination, and very, very much that contemplation phase, it's particularly powerful. So we're just going to move on now to talk about the spirit of motivational interviewing. So there are 4 sort of aspects of the communication style which are often said to be behind the spirit. And the first aspect is being evocative, and what we mean by that is we are seeking to call forth the person's own motivation and reasons for change, and that's really central to what we're trying to do. So it's not something that can be imposed by us as a GP or from outside. The second thing is it's collaborative, okay, so it's like a partnership. There's not this idea of there's an expert and someone receiving expert advice necessarily, but it is about guidance. It's person-centred, which means that it's often, the patient's often stuck, and it's our job to try and understand from the patient's perspective how they're seeing the situation, and to recognise that it's the patient's job to resolve their own ambivalence, and it should always be empathic. So, that means we want to try and understand from the patient's point of view how things are, and often a powerful way to do that is actually just to reflect that back to the patient. So again, we're just going to look at some demonstrations of consults. So the first one is just a very short video. Hang on a sec. And this is a video of how not to do things. This is the complete opposite to motivational interviewing.
I have this fear of being buried alive in a box. I start thinking about being buried alive, and I begin to panic.
Has anyone ever tried to bury you alive in a box?
No, but truly thinking about it does make my life horrible. I mean, I can't go through tunnels or be in an elevator or in a house, anything boxy.
So what you're saying is you're claustrophobic.
Yes, that's it.
All right, well, let's go, Catherine. I'm going to say 2 words to you right now. I want you to listen to them very, very carefully. Then I want you to take them out of the office with you and incorporate them into your life.
Well, shall I write them down?
Well, if it makes you comfortable, it's just 2 words. We find most people can remember them.
Okay.
You ready?
Yes.
Okay, here they are. Stop it!
I'm sorry?
Stop it!
Stop it?
Yes, S-T-O-P, new word, I-T.
So, what are you saying?
You know, it's funny. I say 2 simple words, and I cannot tell you the amount of people who say exactly the same thing you're saying. I mean, this is not Yiddish, Catherine. This is English. Stop it.
So, I should just stop it.
There you go. I mean, you don't want to go through life being scared of being buried alive in a box, do you? I mean, that sounds frightening.
Yes.
Then stop it.
I can't. I mean, it's been with me since childhood.
No, we...
What we're going to do now, if it could be that simple, stop it, is have a demonstration which picks up on the spirit of motivational interviewing. So we're going to hear from our Dr. Sarah and patient James again. And so just try and pick up on the kind of, the evocative, person-centred, collaborative, and empathic way of talking. Don't get hung up on those words, just sort of try and pick up on the spirit of this.
Hi James, we had a chat last week about a lot of things, and one of your concerns was about drinking. I was wondering if you were feeling anything about that this week.
Well, look, I mean, I don't think it's going that well. I mean, I've kept up my pact of not drinking on Mondays, Wednesdays and Thursdays, but it's still pretty much an open pub at my house all the other days, so I just don't feel like I've really moved forward.
So you've maintained your 3 alcohol-free nights a week? No, that's pretty good. If you look back at where we were when we first started 3 months ago, you were drinking every night. You said you'd never had a night off.
Yeah, well, I mean, my boys have soccer practice on Monday and Wednesday, so I really want to be sober for that.
Okay, well, I can see you really value your time with your kids, and you want to make the most of it. That's fantastic.
Yeah, well, I mean that's right. I do want to have time with them. I don't want them to remember me as an alcoholic. Julie keeps reminding me of that. I don't want them to see me that way.
Okay, so you've been able to maintain those 3 alcohol-free nights, and you're finding a lot of motivation comes from your family. That's really important. You've mentioned Julie has some concerns. What is she concerned about?
Quick pause button. You can hear the GP's not saying what her concerns are at all. She's talking to James and asking James about, he's expressing he's in a good relationship with his partner, so what are her concerns? That's a really powerful thing to ask. Continue.
Well, I mean, she had a pretty tough childhood. Her dad was an alcoholic, and she keeps comparing me to him. She says, why does every woman marry their father, which just sets me off. I mean, he was a total asshole, violent. I'd never touch my kids or Julie like that. I just have no respect for anyone who does that.
Okay. So it seems you feel quite strongly about that, and you definitely don't want to be compared unfairly to her father. You've got some good insights about how alcohol is affecting your relationships.
Yeah, I mean, I guess I have insights, but I really want to do something about it.
Okay. So I hear what you're saying is that you'd like to cut down your drinking so you'll be in better shape to look after your family and continue that relationship with them. You've made a good start. How do you think you can keep this going?
I mean, I don't know. I'm not sure how much more I can do. Maybe set a date and try to cut down a bit more.
Okay, you're right about that one. You need to choose the time that's right for you, and we'll go see how things progress from here.
Okay, that's great. Yeah, so that's the spirit of motivational interviewing. What we're going to do now is look at the actual techniques that you can use, and that will help you move into that flow and that spirit in your consultations. So we often use an acronym OARS, the OARS skills, and this is going to be really familiar territory, I think, to all of you. So we talk about open-ended questions, affirmation, reflection, and summarization. So we're going to give that a little bit of attention now, but first of all, we're just going to have a demonstration of the opposite to open-ended questions, closed-ended questions, and let's see how that consult goes.
So it's interesting what you were saying about your ice use. Has it changed over time?
Not much.
Has anyone ever told you that ice is harmful for you?
Yep.
Did you ever want to give up ice?
Sometimes.
It's a bit of a dead conversation, isn't it? So it doesn't work too well. So let's contrast that now with some open-ended questions that our GP is going to ask.
So it's interesting what you were saying about your ice use. I'd like to hear a bit more about it. Tell me about, has your ice use ever changed?
Yeah, I mean, look, I started to use when I was 17 at parties, and as I got older, sort of found more reasons, more parties, and started using it every week.
Okay, what have people told you about your ice use?
Well, my girlfriend's worried that I'm going to mix it with something and not wake up, and she hates how much money I spend on it. God knows what my daughter thinks.
What makes you think that you'd like to make a change?
I'm not sure. I felt really ashamed once when my daughter told me that the reason she never brings friends over is she's worried they might see me when I'm affected.
So you can hear that the GP is trying to understand things from the patient's perspective, and we've got to put aside our values and our goals and let the patient define what the goals are. So let's now demonstrate some affirmation. We're actually going to start with a consult where the GP is the opposite to that, not at all affirmative, and let's hear how that goes.
I mean, look, Doc, I've been using ice for about a year, and I know it's taking its toll. I've still got my job, but I don't know how long I can keep going. I'm just so exhausted.
If you don't stop your ice use now, your family will never forgive you.
I don't know if I can just stop everything together, but I think maybe I can cut out the ice so long as I can just keep going with the beers.
I think you're probably using ice because you've got nothing to do all day. Honestly, I think if you start training, get a job, you'll find it much easier to stop using all these substances. Most drug addicts are unemployed or struggle to keep their jobs,
Not so good. So let's hear some affirmative talk from our GP and hear how that goes.
I mean, look, Doc, I've been using ice for about a year now, and I know it's taking its toll. I've still got my job, but I just don't know how much longer I can keep going. I'm really exhausted.
It's really important that you're strong enough to recognise the risks here, and that you want to do something before it gets more serious.
I mean, I don't know if I can stop everything together, but I think maybe I can cut out the ice if I just keep going with the beers for a little while.
Okay, so I hear that you're trying to make a change, and I think you've got the strength in yourself to work things out and develop a good plan.
That's great. So what we're trying to affirm, remember, is change talk. And just a quick word, it's just really important not to be too over the top with that, not too OTT, because we don't want to set up a situation where the patient feels there's some kind of conditionality about returning to us, that they can only come back to us if they've kind of ticked all the boxes and achieved everything. So it's really good with affirmative talk to have questions like, oh, look, that's really great, you've done that. How did you manage to achieve that? So we're going to look at our third technical skill, if you like, which is reflection. Spend a little bit of time on that because there's different ways of reflecting things back. First one is just simple reflection, and that's basically when the GP is paraphrasing back to the patient what they've heard them say, what the meaning is, what the feelings are.
So James, one of the problems with ice use is even with occasional use you can become dependent, and it becomes really hard to stop.
No, I'm not addicted to ice. Even though I use it once a week, I could stop any time. It's not that hard.
So you feel that your occasional use of ice will never lead to you becoming addicted?
Okay, that's a simple reflection. You can feel there's some power in that. So a complex reflection is just basically where, you know, sometimes we're not quite sure we fully get the patient's meaning. We've got to get in there and make a bit of a guess about it and put it together and reflect it back. So let's hear a complex reflection from our GP.
Look, Doc, when I use ice, I feel great. It really focuses me. It energizes me. I mean, well, I sort of feel good, though sometimes I don't really know why I'm using it.
Okay, so it seems like your reasons for taking ice are pretty complicated and pretty confusing for you.
Yeah, so that's a bit more of a complex reflection, very effective way of getting the conversation to continue. So amplified reflection is simply when the GP puts a little bit of exaggeration into the reflection. You need to be pretty skilled with motivational interviewing to use this one, I think. Got to be very careful that it comes from a genuine spot in yourself, never ever sarcastic, but it can be quite effective. So let's have a listen to an amplified reflection where you'll hear a little bit of exaggeration from the GP.
I mean, Doc, I've stopped being depressed since I started injecting ice. I mean, everyone tells me how bad it is, but I think it's helped my energy and also my depression.
So it sounds like you really value using ice.
Yeah, so the patient didn't exactly say, I value using ice, and yet, you know, you can see that there's some truth with a bit of push behind it when the GP's saying that. So just one more example of amplified reflection.
I don't know why my girlfriend is worried about this. I don't use ice much.
So you think your girlfriend shouldn't be worried about you at all?
Okay, and a final type of reflection is drawing on past consults and what people have said and juxtaposing that with what the patient is saying now, because sometimes there can be a contradiction in those things. That's what's called a double-sided reflection. So we'll just have a simple demo of that now too.
I mean, I get it, but I just can't quit ice. All my friends are still using.
Okay, so you're saying that you can't imagine not using ice with your friends, but at the same time you're also worried about how it's affecting you.
Great. And our final OARS skill is summarization. So that's when we're presenting back quite a bit of what the patient has said to the patient, to our patient, and it's important because it allows us a chance to check out that we have understood what the patient has said clearly. That's really important. And I think it's also a really powerful rapport builder because it is also a demonstration how carefully we have been listening and tuning into the person who's sitting and talking to us. So we'll just have a demonstration of a summarisation.
Okay, so let me just try and pull this all together. Now, tell me if I've missed anything that you feel is important. So we started out today talking about your ice use. You've told me a couple of things. You use it once a week, and you aren't worried about becoming dependent. But you've also said that your girlfriend is worried about you using ice, including the amount of money you spend on it. And then you also feel shame that your daughter doesn't want to bring friends around. You feel that it helps your energy levels, but sometimes you're a bit confused about why you take it. Does that kind of sum up everything today?
Yep.
Okay. And is there anything that I missed?
That's great. Okay. So just moving through the processes and the techniques of motivational interviewing, another part of motivational interviewing is focusing, and that's basically where we're trying to get the patient to come in and be a bit more specific about what their goal is actually going to be. And maybe it's a specific goal, or maybe it's some things that have to happen before they can actually get to that specific goal. But let's have a listen to a demonstration of our GP helping James focus in on a goal.
Okay, so you mentioned earlier that your girlfriend was worried about a few things. Which of the things that she is worried about are concerning for you?
I mean, probably the money. The grog cost me $200 a week. And I suppose I'm worried about my liver as well.
Now that you've come this far, what do you think you're going to do about these concerns?
I mean, I think I've got to cut down. I don't think it's realistic for me to quit altogether, but I'd at least like to get down to the level where I'm not hurting my liver and I'm not spending so much money. But then again, I'm just not so sure I want to do anything about this right now.
Okay, that's great. So we're just going to try and move a bit quickly through. We're a bit tight for time. So you can hear the shifting of focus there. So I'm just going to go into the next slide. which is about change talk. So when we hear some ambivalence from a patient, we really want to capitalise that and make the most of it. So change talk is basically any kind of statement or hesitant reflection from our patient that includes statements like I want, I wish, I could, I wonder. And in motivational interviewing, we need to take a lot of notice of change talk. And so underlying this, we're trying to get our patients to consider two issues, which is how's their drug use affecting them, and what are the costs and benefits of changing my drug use. So there are some evocative questions that we can ask to elicit change talk, and I've got some examples of them on this slide. And just for the sake of time, they're all in your notes. We're just going to move on to the next slide, but please have a look at those questions later. So these are all about delivering a kind of smorgasbord of strategies to you that you can practice today, hopefully in your small groups, to try and promote change talk. So this slide has got some more easy ones that you can try out. We haven't got time for a demo of these either, but it would be good if you get some time to practice these. So, asking your patient about a typical day or session is really powerful. Walk me through what actually happened at home before breakfast and lunch today, which was, you told me you used some ice just before lunch. So walk me through what happened. You can ask your patient to describe the good and bad things about their drug use. You can ask patients to look back and recall past experiences. That's quite powerful. So asking things like, thinking back to when you were at school, what did you think you'd be doing at the age you're at now? Or what were things like for you before you started using heroin daily? Or you can use extremes. That can be very effective too. So you can ask patients to consider the worst and best things that can happen with their drug use. If you were to cut down your benzodiazepine use, what do you think would be the worst possible thing that might happen to you? So just a quick word about sustained talk. So basically, sustained talk is anything which helps the status quo keep going. We often hear these statements. Have you heard your patients say, I want to keep drinking because it blocks out my grief? That's a really hard one, isn't it? And I can't give up ice now because my boyfriend wants to use with him. Or I've already got cirrhosis of the liver. I've probably only got 5 years left. So what's the point of doing anything about that now? I'm sure you've all heard that kind of talk. And sustained talk indicates resistance. So a concept I want to leave with you today is that resistance is almost always the result of how we, the clinician, approach our consultation. And there are things that we can do that raise resistance in patients. And we know, look, there's relatively few consistent personality characteristics in people who use drugs. People don't, in general, walk through the door with this high level of denial and resistance. So we've got just a quick demonstration of a GP raising resistance in a patient. Just have a listen to this.
I can't stop drinking yet, but I'm going to make sure that I don't put myself or others into danger, because when I drink and drive, I'm just a danger to everyone, really.
Look, the best plan is if I send you to Nepean Detox next week, I'll get in touch with the AOD team and see if they've got any beds.
I don't want to go into detox. Look, my alcohol use is not that bad. I don't need a detox. Besides, the staff there never support you properly. Last time I went home, I drank more thanks to them.
So you could see how in the beginning, James was starting to do some really good harm minimisation around don't want to drink and drive, but the GP had a different set of goal setting going on there, get into detox, get straight off it. And in the end, your patient has ended up not wanting to deal with the problem at all. So what do we do if we counter resistance? There are some really excellent strategies that we can use as GPs. So we're going to have a quick demonstration of some of these strategies that are about deflecting resistance. And the first one is rolling with resistance. So that's really great if your patient is in a particularly sort of oppositional way to wanting to do to every idea you suggest. They just say no, no, no. So don't oppose what they say. Just, people will often come back to a more balanced perspective if you just roll along with what they're saying. So a quick demonstration of that.
But I just can't quit drugs. I mean, all my friends use.
Okay, well maybe after today you can have a think and think about things that we've been talking about, and it can sometimes be difficult to change.
Okay, another way to deflect resistance is to just shift focus away from the problematic issue, and we'll just have a demonstration of that.
But I just can't quit drugs. I mean, all my friends use.
Okay. I think you may be getting a bit ahead of yourself there. Why don't we not focus on quitting, but focus on what's happening right now in your life? Let's stay with what we're doing right now, focus on what's impacting you at the moment, and maybe later on we can talk about that.
Okay, so almost at the end now. So, you know, one of the challenges in general practice is always the time pressure, and I know how that works. So we can sometimes have quite quick consultation times we've got to deal with, and we've got to get people back to allow more time. So on this slide, and you've got a copy of this in your notes, these are just some principles that if you remember and put these into your consults, they'll actually go a long way towards you helping your patients. You know, just always express empathy, develop discrepancy. So that's about helping the patient understand how their current drug use is in opposition to the goals that they're stating, avoid argument, roll with resistance, and always support their self-efficacy. And remember, motivational interviewing, there's no one way to do everything. It's a good consultation to use for some patients at certain stages of their drug and alcohol use. And once you've got people on that plan of action and that determination phase, then you need to know something about specific techniques and management principles of each substance, and that's what you're going to be hearing about after the break.
Thank you so much. And thank you to our
Thanks very much, Sarah and James.